wanted to make a video to talk about some junctional rhythms. So let's take a look at this one. So first things first, the rate. Just by eyeballing it, we know that it is slow. The QRS complexes are more than 6 big boxes apart, so we know it is less than 50. Now 7 big boxes apart is about 43 beats per minute, and this is just beyond that, so I'd say it's about 40. The rhythm is regular. Do you see any P waves? No, the P waves are absent here. This means the impulses are not originating in the SA node like they normally should. This is a junctional escape rhythm. The QRS width and morphology are within normal limits, so this tells us the escape pacemaker site must be somewhere fairly high within the conduction system, and well above the ventricles. So how do we treat this? It depends, as usual, how symptomatic the patient is. If you're thinking about pacing or atropine, if the patient's hypotensive, diaphoretic, or has altered mentation, keep in mind that some of our favorite cardiac medications, like beta blockers and calcium channel blockers, can also cause junctional rhythms. This rhythm can also be seen with anyone with increased vagal tone, such as an athlete. Now let's take a look at one more example. Now again, we'll start by looking at the rate. Now, the QRS complexes are just over 3 big boxes apart, so this is slightly less than 100 beats per minute. There is some irregularity to it, but those moments appear to be isolated to just a few beats. Well, what do you think of the P waves? If you look at the rhythm strip in lead 2, they're inverted. So we know the impulses are not coming from the SA node, but somewhere lower in the atria. There's a brief pause in the rhythm with a few beats of sinus before returning to our low atrial or accelerated junctional rhythm. Because the rates are within normal limits, this should not need any treatment.